This video on management of hyperkalemia, very short video and very technical video. Sometimes many of us get confused what treatment should be given and which treatment not to be given for the patient presenting with hyperkalemia. The definition of hyperkalemia is the potassium level more than 5.5. More than 5.5. This is the definition of hyperkalemia. Now, uh, uh, when we are talking about the management of hyperkalemia, then we have to categorize the patient presenting with hyperkalemia, that is potassium level more than 5.5. So at first, the first step, I would like to talk in the sense of a step. So step 1 will be stop all potassium supplementation or potassium containing food and stop all potassium retaining medication like AC inhibitor, ARV, spironolactone, etc. So this is the number 1 step where we will stop all the potassium containing foods, potassium retaining medications. And of course, with the step 1, most importantly, we will put the patient on continuous cardiac monitoring, as because it is the single most important parameter, that is the cardiac monitoring, that will guide us from time to time which modality of treatment should be encountered on emergency basis. So within the number 1 step, it is the most important to mention that continuous cardiac monitoring is needed for any patient presenting with hyperkalemia. So step 2. In the step 2, we will categorize the patient with hyperkalemia in 3 categories. Category number 1 or category number A, B and C. So in the category A, patient unstable or symptomatic. Patient unstable or symptomatic, ECG abnormal, clearly abnormal. What are the features of hyperkalemia on ECG? This is another video I will talk on later, or I have previously already video on ECG, potassium hyperkalemia, so you can go back. So number 1 point is patient unstable or symptomatic. Number 2 point, ECG clearly abnormal or potassium level more than 7 millimole per liter. So step 2, category A patient, when the patients are clinically unstable or symptomatic, ECG clearly abnormal, or potassium level is more than 7 millimole per liter. So if these 3 criteria meet, then we will go for the further management. So what will be the management for the category A? At first, very urgently, we will discuss with the patient or patient family member regarding dialysis. Patient needed dialysis on emergency basis, and for that process or for further better management, patient may need transfer to tertiary care hospital. If we are now treating at secondary or primary care hospital, so patient need dialysis whether it is possible or not in my present institution. In that case, if not possible, patient may need transfer to tertiary care hospital. Before approaching to dialysis, we should or we must start some treatment. So what are the treatment? Number 1, IV calcium gluconate, 10 ml 10% about the 10-minute rule of 10. So this is the number 1 treatment modality should be given in this category of patient to stabilize the membrane, that is the cardiac membrane, to prevent or to treat cardiac arrhythmia. So first point is giving IV calcium gluconate. Then salbutamol nebulization, IV glucose plus insulin. All we know this treatment modality, and if any metabolic acidosis there, if there is metabolic acidosis, we should go for bicarbonate IV. So these and of course we will prescribe the patient potassium binder like resonium. This is called potassium binder. This resonium inhibit the potassium absorption from GI tract. So these are the treatment given for the category A patient where calcium gluconate is the mainstay of management. Now we will proceed for category B subclass. What are the criteria of this group? Patient asymptomatic, clinically stable, same meaning. Number 2 point, ECG fine, normal, no abnormal feature of ECG, and potassium level, mind it, in the category A, potassium level was more than 7. So, and in category B, potassium level less than 7.0 millimole per liter. Mind it, patient clinically asymptomatic, unstable, ECG clearly normal, and potassium level less than 7. Actually, it is 6 to 7, because in category C we will talk regarding the potassium level less than 6. So in the category B, the potassium level actually within 6 to 7, that means less than 7. ECG normal, patient stable clinically. So all the treatment given in category A should be given in category B except IV calcium gluconate. I repeat again, in category A we have given IV calcium gluconate plus salbutamol nebulization, glucose and insulin, if metabolic acidosis is present, bicarbonate, and potassium binder. In case of category B, where patient is asymptomatic, ECG normal, potassium 6 to 7, that means patient's resting membrane potential is normal, fine, and membrane is stable, cardiac membrane is stable. So calcium gluconate is not needed in this group of patient, but other modality of treatment, that is salbutamol nebulization, glucose IV, of course, IV glucose plus insulin, potassium binder, that is the resonium, and if metabolic acidosis is present, you can go for IV bicarbonate if needed. So these treatments should be given in category B. I repeat again, because it is very much important, and sometimes we get confused that whether calcium gluconate should be given or not. Calcium gluconate should be given in those patients, only those patients who are presenting with clinically unstable potassium level more than 7, when the resting membrane become or would like to be unstable, or already ECG having the features of hyperkalemia. In that case, IV calcium gluconate should be given. Otherwise, calcium gluconate should not be given. So now we will proceed to category C, or group C, when the patient is stable, of course, asymptomatic, stable asymptomatic, ECG criteria, of course, normal, and potassium level less than 6. Actually it is 5.5 to 6.0, as because more than 5.5 is hyperkalemia, so it is 5.5 to 6.0. Actually it is the mild hypokalemia. So in case of mild hypokalemia, don't be aggressive, try to understand the underlying cause, as it is transient, acute, subacute, or chronic. So consider whether treatment is needed or not, and you have enough time to think yourself. If needed, if you think it is needed, it is subjective decision. If it is needed, you think, or your consultant think, salbutamol, number 1 treatment modality, salbutamol nebulization can be given, and the potassium binder like resonium, and other drugs like polystyrene sulfate can be given. Polystyrene sulfate can be given, and of course already mentioned, if metabolic acidosis is present, metabolic acidosis can be present in mild hyperkalemia, mild, moderate, severe. In any degree of hyperkalemia, metabolic acidosis is present. So if metabolic acidosis is present, you can go for bicarbonate IV. So this is all regarding management of hyperkalemia. In a nutshell, what is the take home message of this video? Actually, take home message of this video actually is, when will you consider IV calcium gluconate? IV calcium gluconate will be considered only in case of ECG showing abnormal feature of ECG showing the feature of hyperkalemia, patient clinically unstable, potassium level more than 7. Just potassium level exceeding the level of 7, you should go for calcium gluconate, as because in the state of hyperkalemia, when the level of potassium more than 7, resting membrane potential becomes very much unstable, and patients prone to develop cardiac arrhythmia. So to hold or to prevent this cardiac arrhythmia, whenever you will see the potassium level of more than 7, you must go for calcium gluconate. Otherwise, you will miss the patient. Hope this video will be helpful for you. If anyone else any question, any query, any comment, positive or negative, no matter, please put on the comment box. Thank you very much.